So as we all know, the most popular technique for posterior lamellar keratoplasty today are DSEK and DMEK. In a recent study conducted in US, the number of cases which underwent DSEK was 20,000 and DMEK 7,000, indicating DSEK is the most popular posterior lamellar keratoplasty, especially in eyes with complex anterior segment anatomy. Hence, anything which compromises the outcomes of DSEK is very important to be understood. In a study published by Das et al., corneal edema post-cataract surgery was the most common indication for DSEK at a tertiary care facility in South India, followed by endothelial dystrophy and failed grafts. So coming to our study, the purpose of this study was to evaluate the demographic profile, clinical characteristics, and outcomes of DSEK graft rejection at a tertiary eye care facility. It was a retrospective analysis of patients diagnosed with DSEK graft rejection from May 2012 to February 2019. 61 eyes of 61 patients were included, out of which 6 patients did not follow up after the first episode of rejection, hence were dropped out of the study. A standard DSEK surgical technique followed was pre-cut eye bank prepared tissues were used, where a donor size of 8 to 8.5 millimeter and the DSEK lenticule was inserted inside the anterior chamber with sheaths glide. Postoperative management consisted of topical broad-spectrum antibiotic and steroids, which were gradually tapered and maintained at once or twice daily. Shifting our gaze to the results obtained in this study, the mean age group in our study was 52.44 with a range from 12 to 83 years. Coming to gender, females were 31.48% and male 68.52%. Laterality, there was no significant difference in the right and the left eye. Indication of DSEK for graft rejection, prior failed graft, including both post-penetrating keratoplasty and endothelial keratoplasty, was the most common indication, and one of the significant findings noticed in our study was post-inflammation, that is toxic and viral endothelitis, and iridocorneal endothelial syndrome had a high proportion of graft rejection. Coexisting parameters and comorbidities was noticed in 64.81% proportion of patients, among which secondary glaucoma was the most common ocular comorbidity reported. Clinical factors of DSEK graft rejection. According to the study published by Price et al., endothelial immune response post-DSEK graft rejection is so subtle that most of the patients in their study were picked up on routine examination. On the contrary, most of our patients presented to us with complaints of pain or photophobia, and clinical feature diffuse corneal edema was the most common feature reported, followed by keratic precipitates. Diffuse corneal edema with KPs, sectoral edema, keratic precipitate, and one patient presented with AC reaction with a streak hypopyon. Time since surgery, most of our patients presented with graft rejection between 6 months to 1 year. Now, graft recovery in our study subjects, 31.48% of our patients did not recover after the first episode, 46% patients recovered completely, and 22% had a partial recovery. So after this, we did a risk factor analysis for non-recovery among the patients, in which we noticed that patients who presented before 7 days of graft rejection had better outcomes and better chance of recovery. The number of transplants done before did not have a significant effect on recovery post-rejection. IV methylprednisolone also did not have a significant role in graft recovery. Using topical steroids when complaints started also did not have a significant impact on graft recovery among this subgroup of patients. Endothelial cell loss after rejection. This is a clinical photograph of one of our patients which shows that endothelial cell loss after graft rejection episode was almost 50%. So when a mean data was calculated, most of the patients had a mean cell loss of 38.87%. So to conclude, the factors which influenced recovery according to our study was young age, poor visual acuity at presentation, and late presentation, that is after 7 days. When we compare to the findings of our study with the studies reported earlier, Our study had a younger age group, that is 52.44. Indication of DSEC most common for graft rejection was failed graft. Ocular comorbidities, as seen from this table, it is similar to what was reported in other studies, that is secondary glaucoma was the most common association. Time point of first rejection was also almost similar to other studies reported, between 3 to 12 months. Thank you.
What is the standard protocol for management of graft rejection at your institute?
So ma'am, actually in these patients, some of the, for like after DSEC graft rejection, in the earlier years till 2012 to 2014, there was administration of IV methyl prednisolone in patients who had like hyperacute graft rejection with significant edema. But after 2014, we have not been giving oral or IV methyl prednisolone. It has been only topical steroids and cycloplegic.
What about triamcinolone acetate injections, either subtenons or?
No ma'am, we do not give, like for any of the graft rejections, I have never seen being given it.
And oral steroids?
Oral steroids also no ma'am.
How many cases of HSV were there in this group, subgroup?
6 patients, sir.
6 patients. So, how did you differentiate between the recurrence of HSV endothelitis and the rejection?
So, sir, if it is recurrence of HSV endothelitis, then there should be involvement of both graft and the host.
Right.
And in case of graft rejection, it is mostly the graft, the graft which is involved. The edema is more restricted to the graft DSEC lenticule, and the pigments or the keratic precipitates is also restricted to the grafts. But in case of HSV endothelitis, there will be involvement of the host also.